Everybody, my name is Raymond Helbach. I'm a neurologist, neurointensivist from Medical University of Innsbruck, and I'm happy to chair that session with Arti Sarwal from North Carolina. The topic is, will the patient wake up? I think that's an important issue we are confronted with in ICU care, with lots of patients, consult a lot of people doing additional diagnostic tests, and I think we have some very important speakers, very important topics around that could help you also in future to deal with this problem. So the first speaker is Jan Claassen from Columbia University, and he's done fundamental work in EEG and prediction of patients who are going to wake up, and I'm really happy that you're here and give us some insights in predicting recovery of consciousness. Thanks.
Thank you, Raymond. Thank you, Arti. My slides. Great. All right, so title of the talk, I'm from Columbia University, New York. Title of the talk is Predicting Recovery of Consciousness. Here are my disclosures, my funding. These don't really directly relate to the topic here today. So I will start by talking a bit about what is coma, sort of what are we even talking about, because I think that's important to sort of center the recovery around that. What are our current assessments of comatose patients, and then how do we predict recovery? Oh, that changed, but it's the same. And then I will talk about cognitive motor dissociations. So what is coma? If you just want to define it, it's a state where the patient lies there, they have their eyes closed. I mean, the first descriptions go way back in history by Hippocrates, and they basically he described patients that were just lying there like they were asleep. They looked like they were asleep and couldn't be woken up from the sleep. And basically what that means, the eyes are closed. As soon as you open your eyes, you're not in a coma anymore. They do not arouse to vigorous stimulation, and they may have some grimacing and some stereotyped motor responses, but they don't really purposefully move their limbs. If you depict it on this little pictogram here on the side, Stephen Loris put this out a couple of years ago, on two axes of arousal and awareness. Normal consciousness has full awareness, full arousal, and coma has very depressed arousal and depressed awareness. So what is the cause of this? What can be the cause of this? So this is not one disease where you look at the patient, you examine the patient, and you know what's the underlying cause. Mechanistically, the common denominator that there's a decreased withdrawal of excitatory synaptic activity. That sounds very fancy, but if you look at these little pictograms here on the left lower side, what that means is there's a number of different etiologies. So you can think this pictogram depicts a patient, for example, that has a cardiac arrest or hypoxic injury. The black part is basically what's injured. So this patient can look very similar to a patient that has like a midbrain kind of lesion, for example, a tumor or an ICH in the midbrain, or a lesion that is even smaller, focal lesions in the brainstem lower down, like in the pontine area. So there's fancy words, but what it means is there's a number of different etiologies that can lead to coma, even within one disease. And I've shown this picture here before. Even in one disease, traumatic brain injury, a comatose patient can be comatose because they have an epidural hematoma, here the bleeding is, a contusion with hemorrhage, diffuse axonal injury, where all you see on CT scan would be a little ditzel of hyperdensity here. You can have subdural hematoma, subarachnoid hemorrhage, or diffuse brain swelling. You don't know that when you look at the patient. So there's a diversity of underlying pathology that can explain this. Even if you have exactly the same pathology here, this is a patient with an intracerebral hemorrhage. The bleeding is in the cerebellum, the back part of the brain. These patients' CT scans look very different. One of the patients actually fully recovered and two of them died. And I challenge you to say which one it is. You can't really tell that from this. But one of the patients was evacuated very quickly, so the bleed was taken out, Another one, they waited for quite some long time, so the damage was done already. And the third one, even though they intervened quickly, had a cardiac arrest complicating the course. So you have to even know beyond this sort of phenotypic description of what you can see on the clinical exam and the CT scan, you have to know some contextual information to really know what the trajectory of the patient is. How do we determine if somebody is in a coma right now? So the way that we do it is by the behavioral bedside examination. So we go to the bedside and we determine whether somebody is conscious by asking them to do something, and then if they do it, we determine that they're conscious. That is actually not the full spectrum of consciousness, and I'll show you that later on in the talk. If we communicate amongst colleagues about whether a patient is comatose or not, often a scale that is most widely used is the Glasgow Coma Scale. The Glasgow Coma Scale is actually a very crude assessment of neurological function. It has eye-opening, best verbal response, and best motor response. It is a very robust scale. If somebody tells us there's a Glasgow Coma Scale of 14, we know we have a picture in our mind what that patient looks like. But you have to know a Glasgow Coma Scale of 8 can be arrived by many different combinations of these subcomponents. So you don't really know what the level of consciousness of the patient is. The best scale to comprehensively assess consciousness is the Coma Recovery Scale Revised. This was developed by Joe Giacchino. It has 6 different features here, asking the patient to assess basically the visual function, the auditory function, all of these tests to get to a precise assessment of consciousness. It is a great scale. It is very, very hierarchical, so you know exactly what level of consciousness the patient has. It goes very quickly in a completely comatose patient. It goes very quickly if I assess all of you that are awake. But if the patient is in between full coma and somewhere a little bit better, it becomes a very, very long scale to assess. It might take 45 minutes. That's not really practical in the critical care setting. There's a scale that's under development that will tailor this to the critical care environment. So stay tuned for that. So we have to just define a couple of terms. So we talked about coma. Here's motor function. Here's cognitive function. Comatose patients have very poor motor and cognitive function. And patients start to open their eyes, but don't have any command following. They are called to be in a vegetative state or unresponsive wakefulness syndrome. That's a state that's a little bit higher, but does not have any consciousness. Minimally conscious state, the patients have some very subtle signs of consciousness. Either in minus, they may have some alerting responses. They look at you, but they don't follow commands. They track you through the room. You may have seen this in the ICU. That's minimally conscious state minus. And if they intermittently follow verbal commands, then they have minimally conscious state plus. Why is this important? Because if you go to these higher states of still impaired consciousness, those patients have a much better chance to recover later on. So that's why this trajectory on this behavioral scale is actually very important to detect. Locked-in syndrome is not a disorder truly of consciousness, but I put it in here because it's crucially important for every physician to be able to diagnose that. Those patients are fully conscious, but they can't express it. The way that they can express this is typically only by blinking or vertical eye movements. So you have to stand there and ask the patient, not to ask the patient to show you 2 fingers, but to basically, for example, look up or look down. And if they consistently do that, they're actually in this locked-in state. How common? What's the epidemiology of that? For a long time, we didn't really know so much about that. A recent, very interesting study by Daniel Conciella and colleagues looked at the point prevalence of coma and found that 7 to 31 per 100,000 patients were in coma in the UK and the US, and the incidence was 135 to 258. Probably it's actually much higher, but this gave us a first estimate how common that is. Impairment of consciousness is common, in other words, and how do most of the patients with acute brain injury with impairment of consciousness, how do they do? Most of them die in the context of withdrawal of care. So somebody sits down with a family and says, there's no chance for meaningful recovery, and then actually we withdraw care. So a huge weight is being put on our ability to predict who's going to recover. Because what we tell the family has huge impact on how these patients will do. This has been shown in TBI, in ICH, in acute ischemic stroke, and cardiac arrest. We did a study a little while ago in Japan, where we did this study in Japan because withdrawal of life-sustaining therapy is not very common there. So you could get an idea about a little bit closer to the natural history of these patients, and identified 40 patients that were deemed to have no chance of meaningful recovery within 1 to 4 days of the onset of the injury. And we found that, yes, statistically, most of the times the physicians were correct. At 6 months, the patients, most of them had died. But there was a small minority that actually had good functional recovery. One had a Glasgow outcome score of extended of 5 and one of 4. So that's not large numbers, but you have to know that, because if you talk to the families, that is something that you have to put into the context. And to people that basically say, this is what's going to happen, I'm not sure what they're basing their predictions on. So we want to go potentially beyond just our clinical bedside assessment, and there's the behavioral exam. There's a number of ways we can do this, and you'll hear a bit more about this later on in the talk, I think. You can look at the brain at rest. You can expose the brain to a stimulus, like a passive stimulus, like an electrical or auditory stimulus, or you can actually engage the brain in an active task, and I'll show you some data on that. The resting assessment of the brain can be done with electrophysiology, for example. So you have the EEG there running, and you analyze the EEG, and based on comparison with population-based experience, what a patient's EEG looks like in coma versus minimally conscious versus conscious state, there can be a classification that is derived, and patients can be classified as likely comatose or likely not comatose. That is just a probability, right? So you can see here, if you have if you have based on EEG, here classified from EEG, a prediction whether a patient is not conscious, so vegetative state, or minimally conscious. You can actually compare that to the reality if you have a data set that was not used for the training. And in this study, what the investigators did, you looked at the accuracy of that prediction. And they found that in 33% of the patients, it was actually inaccurate. What was fascinating in this study from Paris was that those patients that were classified by the EEG to actually be conscious, but in reality, in clinical exam, they were unconscious, they had a much higher chance to later on recover consciousness. So potentially the EEG detects something about that functional connectivity that's already there that predicts the future recovery of consciousness. You can also not only assess the functional connectivity, the function of the EEG, the function of the brain by electrophysiology, but also by MRI. So this is done in these studies where they use a technique called resting state MRI, where you look at how one part of the brain is functionally connected to another part of the brain. And you can come up with these maps that are there that correlate with the behavioral state. So this is called the default mode network, and that was found to be correlated with consciousness. When these function MRI derivatives were put into models, they actually added to the prediction accuracy together with these electrophysiological techniques in a study by Daniel Conciella published last year. So there may be some potential just by looking at the brain at rest using electrophysiological and imaging techniques in addition to our clinical exam to assess the level of consciousness and predict the potential of recovery. The most precise way to get one number that correlates with consciousness is this technique. It's a little bit complicated. It's perturbation complexity index. Basically what it does is it gets an MRI first, looks exactly at the individual structure of the brain in that patient, and then they use magnetic stimulation and stimulate one specific part of the brain and look at how that stimulus is propagated across the brain. That gives you an idea about sort of how that brain is functionally connected. That is not available for clinical practice at this point in time. I just wanted to put it in here to see what maybe hopefully will be coming in the future. Briefly about active perturbation tasks. So this is a technique that started all by Adrian Owen's paper in 2006, where he had a patient, it was a young woman that had TBI, and she had been in a vegetative state. So remember, the patient opens their eyes, but they don't interact with you, they don't follow commands. She had been in that state for 6 months, and then he put the patient into an MRI scanner. And in this technique with MRI, you can visualize blood flow in the brain. And he asked the patient to imagine walking through your apartment, and then stop imagining walking through your apartment. Then he asked the patient, imagine playing tennis, and stop imagining playing tennis. And those two contrasts of blood flow maps, they could subtract and then identify just the parts that were activated for this task. And what he found, to everybody's surprise, was that this patient that looked behaviorally like she was in a completely unresponsive state had very similar activation patterns in the brain compared to healthy controls. So this is functional MRI. I don't know about your unit, but for me, it's not so easy to get an MRI scan in a patient that is unconscious, comatose, maybe with an ICP monitor. This is actually quite challenging. I can, if I'm lucky, get it once in a hospital course, but that's it, right? And if you want to have a behavioral exam, that fluctuates, right? So you can't repeat it every hour, right? Obviously. So that's going to be always a limitation of the imaging techniques. So a couple of years ago, what we thought is, can we use EEG for this? And recorded EEG while we exposed the patient to keep opening and stop opening your hand. And then analyzed the EEG, did a power spectral density analysis where we look at power in different frequency bands at different parts of the brain, and put this in a machine learning algorithm to determine whether systematically the response to the move compared to the stop move command was different. And we found that 15% of the patients actually systematically activated their brain differently when they heard keep moving compared to stop moving. They were actually in what's called cognitive motor dissociation, so they were conscious to a certain level to distinguish these two commands. And surprisingly, most importantly, the patients that had cognitive motor dissociation, 50% of them recovered behaviorally consciousness before hospital discharge, whereas only 25% of the non-CMD patients did so. And a year later, almost half of the patients had functionally recovered of the CMD patients and only 14% of the non-CMD patients. This is an example of a patient that I saw, and just to sort of put it into clinical practice, her parents had asked me when they stood at the bedside and she was doing anything. They asked, can we talk to our daughter? Is she awake? And we didn't know at the time, and we actually didn't disclose the information during this study, but she was in CMD. And within a week after we diagnosed the CMD, she actually started to show the first two commands, the very first subtle movements of the hand when we asked her to do so. And a year later, she had fully recovered and is working as a pharmacist again. So there is a potential. That doesn't mean you're always correct. Here you can see the trajectory of recovery. These are CMD patients. Not all of the CMD patients recover, but to a much larger degree, the CMD patients recover compared to the non-CMD patients. It is an independent predictor when analyzed together with young age, admission GCS, and etiology of brain injury. And there's a shift across all GOS-E levels for better recovery. So can we use this information then to better define the trajectory of these patients, potentially identify patients that would respond to treatments, and then triage them to targeted treatments, the right patients to support their recovery in the future? That is the goal that we're hoping to achieve. And this is the last slide, I promise. I know I'm a little bit over time, but the last slide, that is what's most important is, what are we really talking about when we say recovery? So if you look at TBI, there's a ton of amazing papers that have come out from TRACK TBI, Center TBI, and the traumatic brain injury model system. We know that a large percentage of patients with disorders of consciousness from TBI recover consciousness. We know that by 12 months, a lot of them recover independence based on these very crude scales like DRS or GOS-E. But what's very important, a paper by Center TBI found that some of the patients that have higher recovery potentially have worse quality of life than those that have a little bit less recovery. So I think we have to focus on what does it really mean for these patients to recover. And that's probably because they can realize more of their deficit. So I think we have to think about that and conceptualize our thinking around that. So that's it. Thank you.
Thank you very much. Great talk. We have time for one question. Is there any question from the audience? So may I ask a question? So as we now know, CMD exists, and we actually know that since more than 10 years. What would be your advice for the participants here? Can they evaluate? Can we evaluate that state now, or is it too early? Do we need more techniques, automated techniques?
Yeah, I think there's a danger of if you detect it and it's not accurately detected. There have been some studies that actually did that, and then false detection may actually send the wrong message. There are some behavioral scales that actually looked at this, where you can by very careful examination find some patients that you don't even detect by the CRSR. So that could be done behaviorally at the bedside. There's also some techniques that were developed where you put an EMG electrode on, and you look after command, you can look at the EMG signal. That's relatively easy to do, but that's not going to detect CMD itself. The true CMD you can only do by these techniques. What we did is we shared the algorithm to analyze the EEG, so that's publicly available, and we're sort of developing right now a broader scale approach that in a simplified way allows you to detect this. But what's important is the EEG that we used here is not some fancy research EEG. It's not like, sometimes you have these 256 electrode EEGs. It's none of that. It's the regular EEG that we had available in the ICU. It's your regular 1020 system, 19 electrodes. You just have to record it. You just have to time sync it very well with the command and then analyze it. But it's relatively straightforward, but right now it's still in development for public consumption, I would say.
So good luck for your future research to provide such tools. Thank you very much.
Thank you.
And as we look forward to more work from Dr. Claassen and his group, I'm happy to invite our next speaker, Dr. Patrick Honoré. I hope I said that name right, from the UC Leuven Medical School at UWOR, Belgium. And he will be talking to us about when to check ammonia in the absence of liver failure when evaluating disorders of consciousness.
Good morning. Thank you, Mr. Chairman. So if I can have my first slide. So my task in the next 15 minutes will be to try to convince you that when to check ammonia in the absence of liver failure is something important. And I think for decades we've been overlooking this. And me the first, don't worry. So, overview. So when to check, which symptoms could help us to suspect hyperammonemia without liver failure. This is very important. Okay. Etiology. Increase production of ammonia, decrease clearance of ammonia, makes sense. And then multifactorial. Okay. Aggravating factors all the time, favoring hyperammonia in the absence, again, of liver failure. Sepsis is one of the leading causes. Treatment algorithm, what should we do? Then adjuvant treatment for, let's say, chronic cases, mostly urea cycle disorder, and rescue treatment in severe cases. Now, what kind of symptoms do we look after? Well, we can have gastrointestinal symptoms, nausea, vomiting, anorexia, abdominal pain, psychiatric delirium. I remember a case a long time ago, and the psychiatrist is calling me. He said, my patient has some kind of delirium. And I said, gosh, I'm so busy here in the ICU. I will come later on in the afternoon. I came in the afternoon, but the patient was already in coma. And then we did everything, CT scan, EEG, full examination. Patient had some fevers. We did some LP, but nothing came out. And I just remember at some point that I saw a case report showing that in some case, coma can be due to ammonia, elevated ammonia, without any single sign of hepatic liver failure. Okay, so regarding neurological, coma, lethargy, confusion, agitation, seizure, ataxia, slurred speech, increase or decrease muscle tone, headache, brain edema, pseudostroke, acute loss of vision. Now, which are the more important? It's obviously very crucial. Confusion, 45%. Vomiting, 42%. Convulsion, 35%. And coma, 42%. Again, unexplained coma without any liver insufficiency. This is really crucial. Now, from this paper, we know that we can have production of ammonia through the cycle of the kidney, through some enzyme in the intestinal, leading to glutamine, and then from the gut microbia, we can have also production of ammonia. Then there is an important organ here, which is the muscles, the muscle mass. And it is really a buffer. When it's worked well, it will pick up all the ammonia in the blood to try to decrease as much as it can. But in some cases, it doesn't work so well. And then ammonia is going into the brain. And that's very bad, as I will show you. Now, decreased clearance, primary hyperammonia. Well, there are a number of enzymes. And you could tell me, well, if we check at a newborn screening, no one will escape. You are fully right. But the majority of the cases are incomplete deficiency. And they will go up to the age of an adult without any symptoms before. And then being in hyperammonemia at some stage. You have also secondary disorder. This is when you have a problem in the carnitine cycle. And you have also disorder due to what you know very well, surely, valproate metabolism, which is taking out beg your pardon. Taking out the carnitine, I beg your pardon. And by doing this, when there is no more carnitine, the urea cycle is stopping. And so you are accumulating ammonia, and this is very dangerous. And carnitine can be life-saving, but not always you need to get it and to give it. So we have also a lot of drug-induced hyperammonemia, anti-epileptic, anesthetic, and then tacrolimus, cyclosporin, acetolamide. And these two, tacrolimus and cyclosporin, are very important because we have more and more transplantation nowadays. And these are suppress the expression of the enzyme. And again, you are rising up ammonia without any liver failure. And then you have also renal problems with whenever you have acute or chronic kidney disease, you will decrease the renal expulsion of ammonia, and you need to use maybe some form of renal support. Portosystemic shunt, I don't want to speak about this because there is always some limited, but some hepatic failure. Now, briefly, increased production. Well, if you are burns, severe burns, glycocorticoid, you will have muscle that works much less, and they do not anymore the buffer that they do normally, and you will accumulate ammonia in the blood. Also, you have microbial ammonia due to bacterial overgrowth, and that can also lead to hyperammonia. If you are having a high protein intake, again, you will have also an increase, especially with parenteral nutrition, an increase in ammonia. Now you have infection, special infection in the urinary tract, what we call urease producing bacteria, that will produce a lot of ammonia, urea plasma protease, morganella, Klebsiella, Pseudomonas, etc., etc. Multiple myeloma, and then seizure, and then some chemotherapy. Okay, so multifactorial etiology, organ transplantation. We have a program of lung transplantation, and why is this? Because these COPD patients, stage 3 or 4, do not have any more muscles. So again, the buffer is waste, and the ammonia can rise after an initiation like an operation. And I saw a few cases. And then bariatric surgery with gastric bypass can not only reduce vitamin B1, but also can reduce carnitine, and this is obviously a key point. Okay, move on. Well, the frequency of the factors favoring decompensation. You see, we can see infection 12%, parenteral nutrition 5%, high protein diet 5%, valproic acid 5%, and postpartum 5%. Okay. Now, what to do? You have a suspicion of urea cycle disorder, but let's say hyperammonemia without liver failure. What should I do? Gosh. And then you measure the ammonia. It's very easy, after excluding a lot of other diagnoses, obviously. And you find an ammonia level above 200 microgram per deciliter, or above 150 milligram per liter. And this is a crucial level. Why? Because patients with this type of hyperammonemia without liver failure do not tolerate at all ammonia in the brain. They really go quickly in edema, in brain destruction, and maybe in death. So you need to go quickly for an hemodialysis. Do not transfer the patient. Do the dialysis on your hospital immediately, if possible. Maximum 4 to 6 hours. Very important. Then you transfer to a reference center to do the chronic business, protein withdrawal, aromatine, L-carnitine, and then sodium benzoate hemodialysis if the level of ammonia is still very high. Now, you see there is a relationship between the level of ammonia and in the blood and the type of coma, but unfortunately there was no classification of coma. Now, you have also chronic treatment, and you see that normally nutrition is one of the key points, but you have also L-arginine, L-carnitine, and in some few patients, 7%, you need liver transplantation without any liver dysfunction. Bad luck. Now, you can also try to remove ammonia from the urine by binding those with either glutamine and glycine, and then you have acid hippuric and phenylacetylglutamine, and you get off of this. Okay, I will skip this one for the time. And now, the patient was taken into hemodialysis too late, and he developed brain injury and cerebral edema, and we need to use the credible therapy, H therapy, but adapted to hyperammonia without liver failure. I just want to stress this. And the classical hyperventilation, reduction of cerebral hyperemia and ICP. Ammonia filtration is not needed because blood ammonia is a very small molecule without any protein binding. So forget about hemofiltration. Just use simply hemodialysis. That's enough. And try to clear the ammonia, prevention of fever, metabolic fluid and electrolyte control. Hypernatremia between 148 and 152, increased serum tonicity causing cerebral dehydration, possible improvement in microcirculatory dynamic anti-inflammatory effect, expansion of intravascular volume without significant overall positive fluid balance. And hypothermia, very important in hyperammonemia without liver failure. Go to 35 degrees using a CRT circuit, and you have a reduced ammonia production, but, very important, a reduced ammonia uptake by the brain, and reduced CBF, and so on and so on. Now, Mr. Chairman, if I may conclude, I would say that when to suspect is when you have confusion, 45%, and coma, 42%. Etiology, 80% of urea cycle disorder, increased production, decreased clearance, and multifactorial, and some others. Aggravating factor, very important. So infection and sepsis as first, some others. Urgent, please. Hemodialysis, urgent. When it's above 200 micrograms per deciliter or above 100 micromole per liter, you will save the guy, okay? Transfer to a specialist center for deeper diagnosed chronic therapy, but after doing the hemodialysis, do not forget. In case of cerebral edema, increase intracranial pressure, use the 4H therapy adapted to hyperammonemia without liver failure. And the main message, please, do not forget this. In any case of unknown diagnosis of confusion and coma, and without hepatic failure, do not forget to measure ammonia, and you will save life. Thank you for your kind attention.
Thank you, Dr. Honoré, for such a comprehensive review of high ammonia in the ICU. Does the audience have any questions? Well, I do have one question for you. In your day-to-day clinical practice, how often do you resort to checking ammonia in the absence of liver failure in your critical ill patients?
It's about 10 to 15% of the patient that I'm measuring. And I have about 2 to 3 positive patients, especially because we have a long program of lung transplantation, and we have quite a lot in those patients.
And what's your therapeutic approach in managing these patients when you see high ammonia? Or what are your thresholds for initiating treatment targeted at reducing ammonia levels?
Okay. I mean, if your patient is in confusion, in coma, having these symptoms, there is no single doubt that if it's due to ammonia, the ammonia will be high. So our cutoff is above 200 microgram per deciliter or above 150 millimole per liter. This is the cutoff. Then you have 1 hour, maximum 4 to 6 hours. Before, as I said before, that the brain that is not have seen any type of ammonia is very sensitive. You know, it's not like a cirrhotic patient seeing this every day. It's very different. So the damage appears very quickly, and you have to be extremely quick in your reply. Once your patient is stabilized with ammonia level, then you have to think about the hypothesis and the type of urinary cycle disorder of some others, and then chronic therapy, depending on what is the cause of it, you see. But first, really try to hemodialyze as soon as possible to protect the brain of those patients. This is crucial.
Is there any difference between arterial blood ammonia and venous blood ammonia, or do you recommend arterial blood ammonia?
I recommend arterial blood ammonia because there are some...
Is there any difference?
Yes.
Yeah, one more question.
So you talk about damage. To me, it sounded a little bit mixing. So I understand that the neurological exam can be affected by ammonia.
Yeah,
absolutely.
Exactly.
Is that what you're talking about when you talk about damage to the brain?
Yeah.
Because I just wanted to understand what you're talking about. Because damage to the brain, you're not talking. Okay.
Fully agree.
So one brief question. First, ammonia is not available 24/7 in several hospitals. So the urgency is a bit. So sometimes you get it only in the morning. The other point, if you have a clinical asymptomatic patients with a high ammonia level, that happens. So would you treat that patient?
If it's if the patient is asymptomatic, I would wait.
Okay. I think that's an important message. Yeah. Thank you very much for your talk. And we're gonna proceed to the next speaker. It's Julia Wendon. She's gonna talk about how to deal with hepatic encephalopathy. Maybe some overlap, but we will see. Thank you very much.
Possibly indeed. Thank you, Chairman, ladies and gentlemen. Right, the liver and encephalopathy, there probably is a bit of overlap. And occasionally we get someone, they say, has got liver failure because they're deeply comatose, but you say, they've not got a transaminitis, they have got high ammonia, they're hypoglycemic. That's a metabolic disorder, it is a medical emergency. So, what is encephalopathy? Well, it's broadly defined as brain dysfunction caused by either liver insufficiency or portosystemic shunting. So if you've got a big portosystemic shunt, it is possible to have encephalopathy, which looks to the world like liver disease because you've got a big shunt, but you've got a relatively normal liver. It might be a bit fibrotic, but it's pretty normal. And it ranges from a real spectrum of neurology, which can also present from subclinical alterations to psychiatric abnormalities. And you should always think about this in terms of that rare presentation. Also think about Wilson's disease if it's a psychiatric diagnosis. So I'm going to split the talk briefly into two bits. The first bit, acute liver failure. The second, much more common, chronic liver disease. Acute liver failure, sudden insult to your liver. Your brain has never been exposed to ammonia before. It's not shifted its osmolytes, and your little astrocytes are very much at risk of change and cerebral edema. So slightly different. So the people who are at risk of cerebral edema are those in grade 3-4 coma. So until they are not talking to you, they are not at risk of hyperacute cerebral edema. The cut points for ammonia where you need to have concern in terms of survival, you see them here, less than 100, 100 to 200, and over 200, you're beginning to move into a high-risk area. But I'll draw your attention to this data is quite old now, and we've probably moved on because we've got much better at manipulating things. So you need to measure it, and it can be done as point-of-care testing. It can be done as a laboratory test. You should do arterial ammonia. If you've only got venous, you've got to assume that your arterial ammonia will be higher. So just be aware of that. You can measure whatever's easier, though. So who's at risk for acute liver failure? These are your young people. They are hemodynamically unstable. They're inflamed. They've got a low sodium at presentation. They've got an ammonia above 150, and they've got renal dysfunction. That's your group who are at risk of cerebral edema. Important, this was data from Jan Claassen, your response to therapy. If you don't delta decrement your ammonia to interventions, and that might be as simple as fluid resuscitation and renal replacement therapy, you are at higher risk of intracranial hypertension. That group less, this group more. I can't remember the last time I put an ICP bolt in. I am probably no longer competent to do it. The management has changed significantly. Age, it's great. Age does protect you from cerebral edema in this context. So my cranium is the same size, my brain has shrunk, there's a bit more space. So this very nice data showing this from my colleague. Whoa, I pressed the wrong buttons. Will Bernal. Right. Decrease risk of cerebral edema with age. So once you're greater than 50, really small. Nothing is new in this world. It was beautifully described back in 1971. So never think you're doing something which is novel and original. But I think our first speaker is, and I think that's amazing. What do you do with these patients? You cool them, but you don't make them hypothermic. You keep them normothermic. You clamp their sodium. You bring it up steadily from whatever the presenting is, usually about 5 millimoles per day. We will usually run at about 150. And then you bring it down at the same rate. And you use bolus hypertonic saline if you need to in terms of surges in ICP or fixed dilated pupils. Renal replacement therapy is very useful in clearing ammonia. It's a water-soluble product, as you heard before. Lactulose and rifaximin and LOLA have no role in acute liver failure. I'm about to show you that they do have a role in chronic liver disease, however. So switching to chronic liver disease. It is a watershed moment when you first become encephalopathic as a cirrhotic. Your mortality is going up. Your first bout of significant encephalopathy should mean that you are being thought of in terms of transplantation. And that's really important for us as intensivists to highlight that if people come into us with encephalopathy. What are the neurological findings? Either no abnormality, you go through this short-term memory loss, difficulty in concentrating, reversal of sleep-wake cycle. That's why they're a nightmare on the wards, because they're up at night and they're asleep during the day, and they get benzos and they get haloperidol or quetiapine, and then they become deeply encephalopathic and aspirate. So your agitated patient on the ward is important to rescue. You then move through lethargy, flapping, inappropriate behavior. Then you become stuporose. You need to be thinking about bringing them into ITU at this time, and they need elective intubation and ventilation. You must also, of course, think of other diseases. Just because you've got cirrhosis and you've got altered conscious level does not equal encephalopathy. Please exclude other causes, and you see some of them delineated there. So, big difference between acute on chronic and acute. One is at risk of cerebral edema, the other isn't. You must protect the airway in both groups. Risks are slightly different. Treatment options are greater for acute on chronic liver failure. So what are the contributory factors? Well, varies between patients, but effectively it's the severity of your liver disease, your comorbidities, so are you diabetic, do you have chronic kidney disease, your age, your level of hyperammonemia, but much less important in chronic liver disease, how inflamed you are again. So this relationship between inflammation and the brain holds for cirrhosis and encephalopathy as for other delirious states, and the precipitating event. But effectively, the more severe your liver disease, the more severe your encephalopathy. We need to think in terms of the neurotoxins and that which we can manipulate, ammonia particularly, bile acids possibly, particularly again with renal replacement technologies, inflammation, and those permissive factors that we may be able to control or we may not. This is some data from our unit. It's a single centre study, so please view it with caution. But we went through 1,000 patients with cirrhosis admitted to the ITU. 320 had significant encephalopathy, of which 173 had grade 3 or 4 encephalopathy as their primary precipitant. And we then split them into acute on chronic versus chronic deterioration, acute decompensation. And we imaged all of them. And what was fascinating is only about 26% of them are normal. You have cerebral atrophy in both groups. You have small vessel disease. We had a significant amount of intracerebral hemorrhage in the ACLF group and a cerebral edema cohort in this group. And they're worth commenting on. They were a child Pew A who'd been tipsed, who had pristine liver function. We tipsed for variceal bleeding and we bumped her ammonia immediately up to 300. And the other two were profound hyponatremia with convulsive episodes. So that mix of hyponatremia and epileptiform activity is really toxic to the brain. And again, in terms of mortality, I would draw your attention to this overt encephalopathy. Years after onset, you're seeing your mortality going up steadily. So please do think about referring them for transplantation. It's a great operation. Ammonia, as I said, doesn't really correlate nearly as well with encephalopathy in cirrhosis compared to acute liver failure. So I measure it to say, if it's normal, I am really looking for another cause. If it's abnormal, I still will look for another cause, but I'm much more content that it probably is encephalopathy. But if your ammonia is 20, something else going on here. If it's 50, 60, okay, that's all right. If it's 100, pushes me a bit more towards it, but it's much softer. And of course, remember that we all recognise when your liver doesn't work, you don't metabolize ammonia, so you get a higher circulating ammonia emanating from your gut. It's toxic to your brain. Your muscles metabolize it, but it's also toxic to your muscles. And of course, your kidneys excrete it. So once you've got that mixture of liver dysfunction and a bit of kidney injury, your rate of rise of ammonia is much more significant. So minor degrees of kidney dysfunction are important. I've talked about this already. Hyperammonemia puts your neutrophils to sleep, so they don't opsonize nearly as well. So hyperammonemia increases your risk of sepsis. So what are we going to do about these patients? Well, we're going to bring them into ITU, we're going to monitor them, we're going to protect their airways, and for chronic liver disease, I would argue that's the most important thing you can do. If you're agitated and you're snoring, you're going to microaspirate, and you're going to get chest sepsis, and then your encephalopathy is going to get worse, and you're going to have to tube them when they've got sepsis. So actually, tubing someone, getting control of their airway is important in encephalopathy, and I would emphasize it. You need staff who know what they're doing, and you need to address the precipitant. So, is it infection? Is it GI bleeding? Have we over-diuresed them and mucked up their electrolytes? Are they constipated? Unidentified. Just look. Be open to possibilities. And do as I said, think about the other things. Is there diabetes out of control? Is this alcohol intoxication or withdrawal? Is it drugs? Is it neuroinfections? Again, this is a group who are at risk of sepsis. Electrolytes, non-convulsive status, psychiatric disorders, recreational drugs, bleeding, multiple organ failure, other things, hydrocephalus, and obstructive sleep apnea is really bad cofactor. I think this is really elegant. It's looking at the cumulative risk of stroke with or without the presence of cirrhosis. And the presence of cirrhosis increases your risk of ischemic stroke, cerebral hemorrhage, and subarachnoid hemorrhage. And I would argue also subdurals, although that wasn't looked here. And by and large, our neurosurgeons, when they see a subdural in a coagulopathic liver patient, will say, really, guys? Not sure. And you've got to really balance that risk. But telling them, of course, they've got balanced coagulation defects, and they don't bleed. But trying to convince neurosurgeons of that is another matter. Right. So what can we do about this? And I recognise I'm running out of time. We can use various things: LOLA, branched-chain amino acids, no evidence base, sodium benzoate, ornithine phenylacetate, lactulose, rifaximin, and hemofiltration, which we've talked about. So the evidence for lactulose, and this is largely in ambulatory patients, is good and decreases encephalopathy. I don't put it down an NG tube. You get small bowel distension. You can't take enough water with it often in an ITU. So if I'm going to use it, I would say it's going to be used rectally. It's great in an ambulatory patient who can take adequate fluids. Some people would have a different view to me, so I've got equipoise. I'm not didactic on this. Similarly, LOLA clearly controls your ammonia and improves encephalopathy. So in chronic patients, LOLA appears to have a good role, both orally or intravenously. And this study nicely demonstrates that, looking at LOLA, dual center study, MELD greater than 21 with encephalopathy greater than 2. And you can see that in the treated group, you have rapid resolution of encephalopathy. It's faster, but the end point is the same of 5 days. So you decide. Do you want to wake them up faster, or are you prepared to take your time? Similarly, this nice study by Jane, again using LOLA in patients and comparing it nicely against lactulose and rifaximin. So does it have an additive benefit? And the evidence would suggest it does, in terms, as you can see there, of delta ammonia, and also in terms of encephalopathy improvement, as you can see here, moving from a high level of grade 3-4 to a much greater resolution of encephalopathy. And indeed, a potential to survival, which I find a bit more difficult to explain. We've talked about renal replacement therapy. We're inclined to use hemofiltration. It's a water-soluble product. It comes out really nicely, and it also allows you to control sodium, and it allows you to control temperature, so it gives you that multifactorial control. And you see here some data showing ammonia clearance and ultrafiltration clearance, beautiful correlate, and more recently published a decrease in ammonia with renal replacement therapy. Should you feed these patients? Absolutely, you should feed these patients. If you don't, they will use their muscle as protein, and then you'll still get the same problem. So feed them high-fiber diet, and there isn't a problem there. And really elegant study by Juan Cordoba many years ago to show that evidence. The guidelines I would commend to you. They are really nice, and they make very clear what the evidence base is, more than I can do in this presentation. So last sort of comment. It takes a while to wake up. Don't fuss. Get a CT if you're worried. Exclude other things. Do an EEG. Make sure they're not fitting. But they will wake up. If you can't find a cause, you've just got to give it time. And I know that sounds really boring, but they do wake up. Thank you for your attention.
Thank you very much for that very comprehensive talk, and especially pointing out how complex these patients are once they have a severe hepatic encephalopathy. I think we have some questions from the audience.
Really amazing talk, really so comprehensive and inspiring. I also love the last comment about they will wake up. I mean, that should have probably been the conclusion of my talk as well. So I love it. Thank you for making that point. One question, so in my practice, in the early years of my practice, I used to use a lot of ICP monitoring in these patients. We have basically moved completely away from it and use non-invasive ways of, and they're not great, but they give us an estimate. Mostly they make us feel better because we don't have to put a bolt in and get the complications. But do you use ICP? What kind of patients do you still use ICP monitoring?
So we used to use it only in the acute, hyperacute cohort. I don't think I've put an ICP bolt in the last 5 years. And I think the last one we did actually was a very young patient. It was a 16-year-old. We use transcranial Doppler along with daily ammonia, quite often done 2 or 3 times a day, and we track the transcranial Dopplers. We're less happy with optic nerve sheath, a bit more into user variation, but TCDs are our go-to test.
Thank you.
Thank you.
In acute encephalopathy, ammonia seems to be the main cause, and in chronic, it doesn't seem to have that much. But in terms of LOLA, acute has got no role.
No.
And in chronic, it does have role. So it's a kind of dichotomy, you know.
So it is a dichotomy, and I think some of it is due to the inflammatory phenotype. So, and, you know, relative changes. I think in hyperacute, the Indian study was very clear that it actually might be detrimental rather than just benign. So we definitely don't use it. And by and large, we have control of ammonia with other modalities, filtration and cooling. It is rare that it is uncontrollable.
And another, there had been a term called chronic hepatic encephalopathy. So now we are not using that word. But we do get patients who are on, you know, chronic stage of mental disorder.
Yeah. So I think that's a cohort that need to be considered for transplant. That's their treatment option. And in the meantime, for the chronic disease, lactulose, rifaximin, and LOLA as conjunctive therapies.
In encephalopathy, where you have ammonia more than 100, so how often do you serially monitor it? And if you have to monitor it frequently, is it advisable to keep an arterial line to do it frequently? So
in acute liver failure, I will monitor it much more frequently. So I will then do it a couple of times a day. And that cohort of patients are all grade 3, 4, they're all intubated, therefore they've got an arterial line in. So that's an easy bit. The chronic liver disease, it's much less impactful. So whether you do an arterial or a venous, I am less fussed about, in all honesty. It's certainly in a ward environment. Most of our ITU patients, again, they'll be tubed and they'll have an art line in. The only time I am much more fussy about ammonia levels is if I've done a TIPS in someone who previously was a child PUA, so they've not really been exposed to ammonia over their last year of life or whatever. That's a cohort where I will check the ammonia following the procedure and monitor it quite closely. And again, I would prefer arterial for that.
One more question.
Brief question, Julia. It's Michael O'Leary from Sydney. I was interested in your graph that showed the relationship between ultrafiltration rate and ammonia clearance. In my place, there's a tendency with some of my colleagues to emphasize this very strongly, and sometimes to even use two dialysis machines, CVHD machines, on an acute liver failure patient, and be very concerned about having very high filtration rates. But I've not seen any good data to support that from a clinical practice point of view, and I just wanted your comment on that. Is that something that you do at King's?
So
and would you recommend it?
We'll start at higher than what would be the standard now. So we'll start, if someone's got pneumonia, say, let's call it 150 for sake of argument, we'll start at 35 mils per kilo, ideal body weight. We will then go up, if necessary, to 45 mils per kilo, but I don't go above that, and I will only be at that dose probably for about 48 hours. Now, my other concurrent VAS cath I use for plasma exchange in that group. And that also has an impact on dropping ammonia and controlling. But I certainly don't use two filters or go above 45.
So one brief question related to that. Is there a certain risk for a too rapid reduction of ammonia? Is that possible? And then do we get CNS side effects?
So
how often do you see that in your clinical practice? Because that's
clinical
important.
practice, I've never managed to drop it that quickly.
Yeah.
It's the honest answer.
Right.
And I don't think anyone's looked at it, so it's a fascinating question, a bit like sodium. But this is a cohort whose ammonias have come up fast, so you could argue that coming down fast is a balanced phenomenon, a bit like taking the sodium up and bringing it down in the same way. But the honest answer is I don't know.
All right. Okay, thank you very much. Very great discussion as well, and we're going to proceed.
Next time, I have the honor of welcoming Dr. Mauro Oddo from the University of Lausanne, Switzerland, and he is going to share his perspectives on what tools does he use when he's evaluating the patient, whether they're going to wake up or not. Dr. Oddo.
Thank you. Thank you for the introduction, and good morning, everyone. So, will these patients wake up? That's the session, and I will try to show you what tools do we have. These are my disclosures in relationship with this talk, and I will try to give you an overview Of course, these overviews are always a little bit selective, but try and giving you a practical view of what can be used at the bedside to improve actually the prediction of coma recovery. And a word that I will use quite frequently is quantification. And I think that there is over the last years an improvement in quantitative tools for coma prediction. And because of time and because obviously also of, again, some selection, I will cover essentially 4 tools that are summarized here, starting with pupillometry. Why pupillometry? Because the first tool which is essential is the clinical examination. And you all know the predictive and diagnostic, prognostic value of pupillary reactivity. And again, an addition, I think, over the last years of coma prediction is the use of quantitative assessment. Now, automated infrared pupillometry is based on the measurement of the pupillary light reflex. There are 2 devices that provide you with quantitative measurements of the percentage of pupillary light constriction, of the velocity of this constriction. These are the 2 main variables. And so if you have a brain injury, pupillary constriction and constriction velocities are reduced. So this is an important addition to the clinical examination, because there are studies showing that the quantitative assessment is superior to the standard manual assessment, and the percentage of false results is actually reduced, can go up to 30–40%, especially in patients with small pupil size. So basically you have a tool which you can use at the bedside, which is precise. And if you go further on this assessment, there is one device that incorporates these measurements into an algorithm and gives you a number, and this number, the neurological pupil index, is giving you not only the pupillary light reflex, which can be influenced, importantly, in sedated patients by sedation and analgesia. So obviously, if you have large doses of fentanyl, the pupillary constriction and the constriction velocities are reduced. But with these computerized algorithm, you get rid of the effect of sedation, and you have a number which is more global and integrates actually the global midbrain functions. So if you have a midbrain dysfunction, the neurological pupil index will be reduced. And then obviously if this is due, for example, to a compression, you can have a reduction that can be reversible with an intervention like treating elevated ICP. So you have a tool to follow up the patients, which is simple, is non-invasive, and is readily available. And there have been studies that are actually, we reviewed in this review 2 years ago, that have linked abnormalities of the neurological pupil index with the prediction of unfavorable prognosis. There was a large multi-center study in cardiac arrest in hypoxic ischemic brain injury, showing a very strong correlation between a low neurological pupil index in between 0 and 2 and a poor outcome with a very, very high specificity, almost 100%, which is what you want to have when you predict a poor outcome. We actually are pretty good, I would say, in predicting poor recovery. So absence of neurological pupil index, absence of pupillary reflex, and also using EEG gives you a relatively straightforward and good information about the prediction of poor recovery. And electroencephalography, especially in cardiac arrest patients, has been repeatedly shown to be a very good tool, and it's the interpretation of the EEG, again, inserting an analysis of EEG that is sort of trying and be semi-quantitative or looking at really the dynamic response of the EEG. And you know that if you have a burst suppression or a discontinuous background, these patterns are associated with poor recovery, and especially the presence of a spontaneous burst suppression pattern. So when the patient is no longer sedated, spontaneous burst suppression after cardiac arrest, but also after other types of brain injury, is a strong predictor of a bad prognosis. Unreactive background has been studied. The problem with the unreactive background is how you reproduce the stimulus. But performed by neurologists who are trained, if you do a powerful stimulus, a painful stimulation, vocal stimulation, and you don't see any reactivity on the background of EEG, so basically there is no reaction, unreactive background is also a strong predictor of poor recovery. This also has been extended to other brain injury populations. So you see that there are signs readily available at the bedside, because these are tools that you have and you can predict recovery quite early on during the first week. And I think the EEG is really an important tool. Now, I would like to highlight during this brief talk what has been already presented by Jan Claassen, the fact that we are improving the prediction of good recovery. And early on, we can identify small subsets of patients that we need to wait, and those patients can recover. And I think that this is a very important information nowadays. We are good in predicting poor recovery, but we are improving also in predicting patients who may eventually recover. Now, this is a study, again, looking at this standardized EEG analysis with the paper that really I invite you to refer, to have this standardized EEG analysis, to also ask the neurologists in charge to really provide you with this analysis. Now, we applied this standardized EEG analysis to a cohort in Lausanne, and you know that there are recommendations now on how to predict recovery after cardiac arrest, pupillar examination, somatosensory evoked potentials, all those signs of highly likely or very likely poor recovery. However, in the reality, 2/3 of these patients by day 3 to 5 are in the indeterminate outcome. So they don't have, these very bad signs which appear concomitantly. So 2/3 of patients, you are a little bit uncertain. By applying the standardized EEG analysis, we were able actually to show and to demonstrate that you can identify a benign EEG tracing. And so you wait, and you even, I have examples of patients were put on dialysis and recovered because EEG did not show any bad sign. Neuron-specific enolase, by the way, was also in a borderline, and I will come back to that. So I think these are important messages. On both ways, you have to insist on care when you have an EEG that is looking pretty okay or not highly malignant, and you can provide information, a clear information to the family relatively early on, and not wait 14 days and remain still in this uncertainty. This has been presented by Jan Claassen, but I think I want to just spend 1 minute, because this, I think, is a tremendous addition to the coma science. And the group of Columbia has really done great studies, and it gives you 3 information. Message 1, this is applicable to the bedside. You need a 19 electrodes EFG, but it's applicable. Message 2, you can use, and this has been discussed during these Congress and will be discussed in the future, artificial intelligence, mathematical modeling, statistical modeling, with algorithm that you can derivate and then apply it to other cohorts using this machine learning algorithm. And the message 3, and more important, is the fact that you can predict good recovery. So this cognitive motor dissociation is 27 patients out of 193, so it's about these 15 to 20% of patients. But for your individual patient, the lady we showed, and for her family, this is a tremendous advance in coma recovery, because we wait and we have quantitative tools available at the bedside that can predict with certainty recovery. And again, this is the addition of clinical examination, EEG, and machine learning. And you see that these green boxes are those patients who progress and can go back and become again a pharmacist. MRI, shortly, there are large studies. The message I want to provide here is, again, quantitative analysis. So this fractional anisotropy, which measures basically the amount of water. So you use MRI diffusion, the diffusion of water, and when you have a lesion, this actually diffusion of water is reduced because you have obstacle. So let's say that the perfect diffusion is 1. If you have a lesion, the fractional anisotropy, so it becomes less diffusible, so this 1 is reduced around 0.4, 0.5. So you can quantify the tissue loss. So lower numbers indicate tissue loss. And you can combine this quantitative analysis. This is a multi-center French study in a cohort of hypoxic ischemic brain injury patients. Now, these MRI were performed after day 7 in patients who were in these uncertain states, because, you don't really know, because you don't have bad signs, but they still do not wake up. And so here you combine MRI using this quantitative approach with EEG. In this case, they were using the former classification by SINEC, but I urge you to go and look at the paper on the standardized, more recent, modern quantification, especially with burst suppression and reactive EEG. And also they were assessing patients clinically. And you see that if we talk about poor recovery, the specificity of this approach was very high. But by the way, you can reach this specificity by a simple tool, which is pupillometry, and combine this tool with EEG. And opening the next talk, there is also a nice correlation between these MRI imaging with the new neuromarkers that will be addressed in the next talk, so I don't spend too much, but saying that NSC for cardiac arrest and NFL for cardiac arrest and TBI are probably the most promising with GFAP. And I would like to conclude with probably the main message, because this paper is out, I think, yesterday or 2 days ago, and it's the multimodal approach. And the second thing is that now it's a multimodal prediction of a favorable outcome. So it's not of a bad outcome. And we used 2 actually cohorts collected in Lausanne and in Boston with almost 500 patients. And I want to especially thank Andrea Rossetti, my colleague, my neurology colleague in Lausanne. And what this article shows is that, again, you have to be comprehensive in your examination, not using one single tool, but combining the tools. And the tools are the neurological examination. Here we use the full outline of unresponsive score. So the 4 score, you have the coma recovery scale. So use neurological scales that are comprehensive. Don't only rely on the Glasgow Coma Scale. Use EEG using the standardized analysis, and you can add one biomarker here, which is studied in cardiac arrest, the neuron-specific enolase. And what you see is the addition of the concordance of these tests. So if you are 3 tests going in the bad direction, the patient is not going to recover, and this is your certainty, and you are more safe. Versus if you add positive signs, and you have this score going up, you see that the prediction for a favorable outcome is also pretty much good. And this is, I think, the main message to provide again. We are good at with bad recovery early on, but we are improving our prediction of a favorable outcome. Thank you very much.
Thank you so much, Dr. Oddo, for this comprehensive and excellent review of tools for neuromonitoring. Any questions from the audience?
Thank you, Mauro. Very nice presentation. So with the multiple approach to predicting good outcome, how do you see it changing what we actually do? Because I guess what we've done in the past, or what we do now, is that we use a multiple approach to predict poor outcome. And unless that happens, we will keep the patient, we will continue care, we will do tracheostomies, we'll wait, we'll keep the patient in the ICU. And I guess wouldn't that sort of be the best bet in order to make sure that we don't withdraw in anyone who could have a good outcome? So how do you see this? What's the benefit? Is it, when we're considering angiography or dialysis or operations, or how do you see it?
Well, I see it as I said. I think the combination of the tools we have, good clinical examination, adding, for example, I was discussing the pupillometry because it's simple and available. EEG, well, I think there is a clear demonstration of really the evidence, the clinical evidence of the role of EEG, but for it, you can't use the simplified EEG. You have to use a complete EEG, and you must have a collaboration with the neurologist. And so if already you have that, then the quantitative MRI analysis is a little bit more complex, because to develop an algorithm with MRI that is applicable everywhere is not always easy. Now, we also are, a little bit dependent on the type of injury. Cardiac arrest is relatively straightforward, I would say. Traumatic brain injury, intracranial hemorrhage is more complex. So I don't think that, you need to use this multimodal approach. And probably the message is that there is a subset of patients, let's say a 20%, in which this approach is useful, and so you need to wait. Now, of course, you need to consider demographics, the patient age, patient condition. Obviously, this young lady, 30 years old pharmacist, you want to have a comprehensive approach. And on the other extent, you do not want to provide too positive messages. And so that's why, maybe not perform tracheostomy on everyone, because consciousness and MCS minus, I'm a little bit concerned about this. And so I think this is the way, and also use, a multidisciplinary approach, not deciding on your own in intensive care, but bringing some people around the table. Maybe Jan wants to add, or Raymond, or...
Yeah, I agree with everything. It's a good question, but I can only speak for myself. I think it sort of depends what the family wants, right? There are some people, it's sort of like, is the glass half full or half empty? Some people just want, is there any chance of recovery? Then actually predicting the poor outcome is actually most important. But I think there are some families that actually want to be in that context. What is the chance actually of a good recovery? So you're telling us, we can tell you that the patient is not going to have a poor outcome, but what is actually the chance of a good recovery? And I think that's understudied. So I think this is potentially, I think how it is implemented in clinical practice will depend a lot on where you practice, what the value system of people are, and that is very diverse, and I think needs to be taken into account. But it's a great discussion. Love it.
And while you have the mic, I have a quick question for both of you. I'm a huge fan of your work, obviously, on multimodality monitoring and what you've done to elucidate the markers for consciousness. But from my perspective, in this multimodality platform, cerebral hemodynamics is very visibly missing. What is your take on, because I see EEG, I see structural imaging, I see exam parameters. What has been your experience or take on hemodynamic information in correlates of disorders of consciousness?
Well, the cerebral physiology information is useful when you treat the patients. And so, you decide that you are in the first day and you treat patients with intracranial hypertension. This is, what was discussed on Tuesdays. You go for multimodal neuromonitoring, and so you can add, for example, brain oxygen. You can use transcranial Doppler as well. So in this approach, you are treating. So you're into the patient. Now you come out, and in terms of prediction, obviously, elevated ICP, low brain oxygen are associated with, a worse recovery, but not necessarily. So, and brain oxygen in a normal range is also sort of reassuring because you can wait before treating, and so the treatments we use were not really sure whether this is actually providing a good outcome. So the cerebral physiology is association that is useful when you treat and gives you information also dynamically, like for example, seeing that you treat the ICP, brain oxygen goes up, and NPI, the neurological pupil index, goes up as well. So I have cases of such patients, and I'm sure that those who use this monitoring approach have the same.
Yeah, I completely 100% agree. I mean, it's sort of like, is glucose important for brain function? Of course it's important, right? But that doesn't mean it assesses comprehensively the brain function, right? So I think they're important treatment targets, management, exactly what Mauro said. I completely agree.
Thank you.
Yeah, I think an important message that dynamic monitoring, dynamic changes are so important, and that keeps also the matter of time. So also in cardiac arrest, we now say that we need more time to predict, and I think that's a very, very important message also from other talks, that time is so important, and if we don't see the cause for not waking up in, for example, neuroimaging or by other tools, we need time, and I think that's a very important message you spread also in your talk.
Yeah, and yes, I agree.
Yeah. So, and I think in the next talk, very, very interesting and supplementary, can biomarkers help us in prediction, and when is the role and which biomarkers to analyze? So, thank you, Mauro, for that very comprehensive talk. And the next speaker is Markus Skrivvars from Helsinki, Finland.
Yes.
And I'm really happy to hear your talk. Thank you very much, Markus.
Thank you so much. Thanks for the introduction. So how biomarkers can help. And of course, it's a little bit focused on cardiac arrest patients, those who are comatose after an hypoxic brain injury, but I'll have some words also on other types of brain injury. I declare some conflict of interest, nothing really relevant to this talk. Mauro nicely outlined the importance of a multimodal approach in your cardiac arrest patient. clinical examination, pupillometry, imaging, EEG, SEP, and biomarkers. In one sense, of course, for the clinician, which are the ones who are very straightforward? Well, I guess clinical examination and biomarkers, because you just withdraw a blood sample, you send it to the lab, and you get a value that you can learn to interpret quite quickly, compared to EEG. And of course, sending the patient to the MRI scan, we all know, is not that easy. One important thing, I'm sure most of you will know this, but the whole concept of predicting something and the concept of area under the curve. And I'll briefly go through with this. It may be something that most of you will know. But of course, if we have a biomarker here in the good outcome patients and there in the poor outcome patients, and there's no overlap whatsoever, then the area under the curve will be 100% or 1.0. So there's no false predictions, no false negatives, nothing. It's all perfect. Area under the curve, 100%. Then if there's a degree of overlap, then the area under the curve will not be 100%. It may be 75% or 0.75. And somehow it's been agreed that it needs to be more than 0.8 or 80% for any biomarker, regardless of what you are predicting for the biomarker to be useful. And that's will then, of course, based on the threshold value that you use. And then, of course, finally, if the values are exactly the same in the good and the poor outcome patients, then there's no use at all. Area under the curve is 50% or 0.5, completely useless biomarker. The other thing that we need to acknowledge is that many studies report if you have a standard biomarker and another one, to compare these, you can look actually at this delta area, so the delta AUC, how much differently does this curve behave compared to that curve. So that's something that's also reported quite often in these papers. And then one other thing, if we talk about a multivariable model and the risk of being dead or alive, then the model will provide a risk, which is the C statistic, which basically is the same as the area under the curve. So, which brain biomarkers do we have? This is from a recent review. Mauro Oddo showed a very similar picture. Cardiac arrest, hypoxic brain injury, we have the neuron, and we had the neuronal biomarkers, so NSC, neuron-specific NLAs, UCHL1. We had the glial cells, so the astrocytes, biomarkers like GFAP and S100B. And then we have the axonal biomarkers, so neurofilament light, and tau protein. And as it turns out, these seem to be very important, especially in the hypoxic brain injury. And of course, the idea is that you take this value, you take blood samples over time, 24, 48, 72 hours after cardiac arrest, and then you measure the level and look at how high the levels are. So for cardiac arrest, this is the guideline. You need to have at least 2 of these in a patient who's in deep coma at 72 hours from the arrest in order to consider withdrawing care. And there in the guidelines, neuron-specific NLA's value more than 70 is there. So one thing that you need to consider is that neuron-specific NLAs is very sensitive to hemolysis. Already shown about 30 years ago that if you add hemoglobin to an NSC sample, you can see values up to 35, 40. So NSC is not good if you have the patient on dialysis, on a balloon pump, or on ECMO. Will not work, and it's not useful for that. Then when we consider what the good outcome is, what we're trying to predict, the strategy in cardiac arrest studies has mainly been to try to predict a poor outcome. So either death, vegetative state, or severe cerebral disability, your inability to be independent, which of course will vary a little bit from country to country. Is that always a bad thing or not? Neurofilament light has been studied during the last years. Here's a study from our group where we looked at this in a fairly heterogeneous population of cardiac arrest patients. So the Coma Care study, 5 centers in Finland and 1 in Denmark, 120 patients with a witnessed ventricular fibrillation as the initial rhythm, ROSC times of 10 to 45 minutes, outcome at 6 months, determined by a person who was blinded to the biomarker levels. We had some frozen samples and we analyzed them in a specialized laboratory in Gothenburg. And this is what it looked like. So the neurofilament light levels here on the y-axis and here on the x-axis the different time points. In blue, the good outcome patients, and in red, the poor outcome patients. And as you will see that already at 24 hours, there's quite dramatic differences in these two levels. And please note that this is a logarithmic scale. So we're talking about levels about 20, 30 in the good outcome patients and several hundreds, even thousands in the neurofilament light levels in the poor outcome patients. So there's really huge difference in this. So what if we then do an area under the curve, a ROC curve analysis, and compare it to neuron-specific NLAs or S100B? One thing we can see that on ICU admission, the biomarker doesn't work. It's very close to 0.5. So the injury hasn't happened in a way that we can measure it with a biomarker yet. But then already at 24 hours, the AUC for neurofilament light was 0.98. So it was almost perfect. And then at 48 hours and 72 hours, very close to 1. We were astonished by these findings. We had definitely not expected to see values like this. NSE at 48 hours and 72 hours, 0.86, 0.85, so also a pretty good value. So this was, of course, a very selected cohort. What about the more common ICU cardiac, the more typical cardiac arrest patient? Well, we had some samples in store that we also used for this analysis. Comparing neurofilament light to neuron-specific NLAs in different types of all comers to the ICU, not only those who were included in a trial with very specific inclusion criteria. So this is data from the Finn-Rasuski study 10 years back, so it was done 10 years ago. Samples had been stored for several years, including all types of cardiac arrest patients, all types of initial rhythms. Outcome at 1 year determined by a neurologist who was blinded to care in the ICU and the biomarker levels. And as I said, the blood samples had been stored. So these are the types of patients that were included. So about 50% had a good outcome, 48% had a poor outcome, mainly shockable rhythms, but also non-shockable rhythms, and also other types of cardiac arrest. So hypoxia, some drownings, hypothermia, intoxications, trauma. So definitely a more diverse cardiac arrest population. So here you can see neurofilament light compared to NSE, neurofilament light here. Again, a logarithmic scale. In blue, the good outcome patients, and in red, the poor outcome patients. And already 24 hours, there's a nice separation between these two groups. And compare it to neuron-specific NLAs, where there's much more overlap. Again, if we look at the area under the curve, again, a value close to 1 is good. So at 24 hours, 0.9 for neurofilament light, 0.64 for neuron-specific NLAs, and also looking at the subset of patients with a non-cardiac cause of the arrest, so hypoxia, trauma, hypothermia, and also in those patients, the area under the curve was very good, 0.88. And then at 48 hours, you can see that neuron-specific NLAs has slightly improved, but neurofilament light remains better with around 0.9. So this was very promising, definitely. There's been a systematic review published in 2022 reviewing all the studies in cardiac arrest. There's about 5,000 patients, and this is kind of showing the same kind of area under the curve. So for NSE, it's 0.84, so it's definitely a useful biomarker to predict outcome after cardiac arrest. Compared to neurofilament light, area under the curve, 0.92, so definitely better based on these studies here. How about other types of brain injury? Of course, this is your typical cardiac arrest patient. The CT scan may show a degree of edema, but no clear sort of focal areas of major injury. Compare it to ICH or traumatic brain injury, subdural hematoma, epidural hematoma, traumatic subarachnoid hemorrhage, or spontaneous subarachnoid hemorrhage, where you have areas with much more injury, and it's quite likely that you could have very high levels of an injury biomarker, and still you could make a good recovery. I mean, we've all seen patients with CT scans like that, and when they're operated on, they still can have a good outcome. But how well do these biomarkers work in other types of brain injury? So in TBI, this is recently published, the Center TBI study, where they took a series of blood samples in all comers, all types of traumatic brain injury, and they looked at the association between the biomarker level and the Glasgow Outcome Scale Extended. And they also looked at what if you have the best available model that we have now, the impact model to predict outcome after traumatic brain injury. What happens if you also add into that model the value of a corresponding biomarker? Will your model behave better? Now, this is, of course, not the way a clinician would like to have it. We don't, in general, do modelings when we have a patient. We just want to measure a biomarker and then see what the level is. And unfortunately, this paper doesn't include that information. But nonetheless, this is the scale they used. So Glasgow Outcome Scale Extended from 8 to for 1 to 8, where usually 5 to 8 is considered to be a good outcome. So here are the GOSC categories long term. So you can see ranging from 1 to 8, and with NSE there's definitely some difference, but not that much. Levels overall being around 30-40. Neurofilament light, much more and much nicer looking values depending on the GOSE outcome scale. Then this is a bit busy, but here the reference model giving you the C statistic or the AUC for mortality, for unfavorable outcome and incomplete recovery. So this is the impact model. And then here showing how much does the model improve by adding the biomarker. And as you can see, so this is the delta AUC value, and you can see that it doesn't really add so much to the model. And of course, this is not the way a clinician would like to use this biomarker. We would like to measure it, get a threshold value. Above this patient is not going to survive, or this patient is going to survive. So definitely more work to be done on using biomarkers in traumatic brain injury. How about subarachnoid hemorrhage? A very recent study, 80 patients, typical subarachnoid hemorrhage patients, more severe bleedings on the Fisher scale, lots of comatose patients. They looked at the different biomarkers in that subset over time. How will that predict outcome? It's shown here. So S100B, interestingly, so that's the this is the good outcome group, and that's the poor outcome group. So S100B, quite a lot of separation. NSC, same thing. But for GFAP, which is the marker of the glial cells, no much difference. And also the protein tau, which is a biomarker of axonal injury, not much difference. And then looking at this in a AUC curve, the values are sort of around 0.7, perhaps 0.8, so nothing really similar to anoxic brain injury. So definitely more work is needed on whether we can use this in predicting outcome after subarachnoid hemorrhage. So, conclusions. I think biomarkers, they're included in the guidelines for predicting outcome in patients after cardiac arrest. More and more studies suggest that NFL is better than NSC, and I think they will replace NSC when there's a commercial kit available that we can use 24/7. A multimodal approach, of course, is always recommended. The use of biomarkers in other types of brain injury, not included in guidelines, and probably to be used in isolation is probably not going to work that well, given the heterogeneous type of brain injuries that we have, for example, with regards to traumatic brain injury. And with that, I conclude, and happy to take some questions.
Yeah. Thank you so much for this excellent review of biomarkers. Any questions from the audience? I think there's one in the back.
Thank you for your presentation. For post out-of-hospital cardiac arrest, we use NSE to neuroprognosticate, but many of our patients are on devices. And so far, we only check signs of hemolysis with plasma hemoglobin. Can I assume that with a normal plasma hemoglobin, my NSE value will be reliable?
So you mean you have a patient on renal replacement therapy
or ECMO.
Or an ECMO?
Yeah.
That's a very good question. I mean, of course, the lab will report the amount of hemolysis, and of course, if you take that into account, then yes, you should be able to use it. But nonetheless, there's very little data on this, and definitely the little data there is suggests that neurofilament light as well is far more superior to NSE in ECMO patients. On the other hand, I mean, hemolysis, some degree of hemolysis is definitely very common in all types of ECMO patients. So I would definitely try to go for as much as possible else in addition to just your biomarker in order to predict outcome in an ECMO patient. No question about that.
Thank you very much.
Any other? There's one.
Thank you, Markus, for an excellent talk. One of my big concerns with biomarkers is that the significance of the biomarkers depend on in what setting you are getting them. And none of the studies that are trying to do prediction models kind of give you the answer in what kind of setting, what kind of care did these patients get. And if you don't know that, that would be as stupid as using CRP as a marker for survival in sepsis if you give or not give the patient optimal care. Mm-hmm. They would signal two different things. Mm. And until now, we have this group of patients has been withheld optimal neurointensive care.
Mm. No, I mean, the coma care sample that were patients that were cared for in a way that we think was the best possible way. It was very high survival, but of course, could they have had even better outcome if they were all treated at Karolinska Institutet? I don't know. It's possible, we may discuss it. Of course, the idea here is probably that if you have a sample from a multi-center study, if you have more studies included, like the TTM samples, TTM2, where you have patients from Europe, from Australasia, and it still works in that setting, then I think it's quite reassuring. And of course, the Finrysaski study, that included secondary hospitals in rural Finland. It included patients treated by regular intensivists, not cardiac arrest centers, they were not receiving 24/7 angiographies, for example. It was regular secondary hospitals, and still the outcome was fairly okay, and in that sample the biomarkers worked quite well. So I must say that we were very surprised with both of these findings, especially the samples that had been frozen for 10 years. We did not anticipate to see this kind of accuracy, but it was there, suggesting that NFL seems pretty accurate for predicting the type of injury. And interestingly, there were some cases who had survival despite low levels of NFL. And we checked these patients, and there was one patient who was extubated on day 2 after cardiac arrest, and he remained in this horrible combative delirium for 1 month. And he received dexmedetomidine and lots of drugs for 1 month. But then after 1 month, he started slowly to recover. And he made a good outcome in the end. And we had 2 cases like this with low NFL, clinically in a horrible state for weeks, but still made a good recovery.
Thank you, everybody. And a big thanks to all the phenomenal speakers for such a good session. And for the sake of time, we'll go ahead and close this session. Thank you so much.